This video is sponsored by the Association of Anaesthetists, A-Line, Health Education Northeast and NEMO.
Thank you very much, Ru and Julia, for joining us for the talks and also for joining us for the panel discussion. I would like to introduce our other panelists who are going to join us today. One of them is Dr. Nancy Redfern, who is another consultant anaesthetist at Royal Victoria Infirmary at Newcastle upon Tyne. She has interest in obstetric and neuroanesthesia, and she's done an immense work in training and also for the college and for our region and the country. She worked for 15 years in the Northern Deanery, first as Associate Dean for less than full-time training, and later as Specialty Dean Director. And she supported head of schools to manage to develop 56 different specialties. She's just finished being Vice President at the Associate of Anaesthetists of Great Britain and Ireland, and she currently co-chairs the National Joint Fatigue Group and runs mentor development programs throughout the UK. And over the years, Dr. Redfern has worked with many doctors who face significant career and personal challenges, including brushes with the GMC and serious bullying issues. Our second panelist is Dr. Mike Wilkinson. He's an SAS doctor. He's one of the SAS doctors at in geriatrics, orthogeriatrics, falls and syncope, at Queen Elizabeth Hospital in Gateshead. And he is passionate about promoting equality, better recognition and improvement opportunities for SAS grades and SAS careers. As I mentioned before, he's Associate Dean for SAS Doctors and Dentists for Health Education England, North East and North Cumbria, and SAS Tutor for Queen Elizabeth Hospital. And he's also representative for SAS Doctor for Local Negotiating Committee and British Medical Association, and also for Royal College of Physicians, Trainees and Members Committee. And lastly, the last person joining us is Dr. Kathryn Bell, who has been introduced before. Thank you very much. So I think the first question I would like to ask is for Mike. He came here to represent SAS doctors, so that will be related to, the question will be related to information and support for SAS doctors. So as we know, SAS doctors are a very versatile group of from minority backgrounds and large proportion of trainees who trained overseas. And GMC reports that some minority doctors and non-UK graduates are more likely to receive sanctions and warnings than white and UK qualified doctors. There is also evidence that they are more likely to experience bullying and harassment. So I wanted to ask, what has been done to address these issues at the regional level? And also, what are the information resources for SAS doctors in this region regarding contact information, recommendations in case of bullying and harassment, and support with career progression for SAS doctors? Thank you, Mike.
Right. Well, thank you very much for inviting me today. I'm really proud to support SAS doctors and dentists. As the panel has heard, I'm already a SAS doctor in our region. And I think it's particularly pertinent that I raise and highlight the SAS doctor community, particularly for this this study day, but also for this topic about leveling the field with challenges in the workplace. And I think that to understand the challenges that we have in the workplace, it's also important to understand the workforce itself. And there's a reason that I think that SAS should be put to the forefront of those types of discussions. As we've already mentioned, a lot of SAS doctors themselves have problems with bullying, undermining, harassment, and a vast proportion of SAS doctors are from BME backgrounds as well. So why are SAS, who are SAS and why are we relevant? Well, this is just a little bit about what a SAS doctor or dentist is for those who don't know. And I think that's part of what the challenges I face on a daily basis is that a lot of what we have, a lot of the attitudes that exist is what Dr. Bellamy was talking about before, about unconscious bias, and perhaps even just not really understanding. So So SAS doctors and dentists, just to put it very simply, have completed their medical degree, that could be internationally, have 2 years of experience after that medical degree, and an extra 2 years of specialty experience in the specialty that they are in. So at least 4 years of experience, and to be quite honest, the vast majority have a whole lot more than that and tend to stay in that career for as a permanent role for the rest of their career. Though of course there are options to undertake CSER, which can get you onto the specialist register and be a consultant should you so wish to be. So the reason that it's important is simply because a vast majority, as I said, of SAS doctors are from BME backgrounds, around 60%, and 7 out of 10 have a primary medical qualification obtained outside of the UK. And that will probably feed in very well to the conversations we've had before about challenges of being new to the NHS, and also to the conversation we're having later about challenges in career progression. So this slide is a slide that's yet to be published by the GMC, but I do have their permission to share it with you today. It's based on the statistics from the SAS LED survey, which we've already heard a little bit about, that was conducted last year. Now, what they were able to do was do a cluster analysis of the findings and try and work out what are there subgroups within SAS, and indeed there are. And it's quite interesting to see that in that subgroup, there are certain characteristics that have both positive but also negative ramifications. For example, the group that concerns me the most as being one of the leads for SAS in our region is Group 2, but also Group 3. 80% of which in Group 3 having their primary medical qualification internationally, 70% of whom are BME and have worked in the UK for a long time, have more unfavourable experiences, especially in relation to their environment, team working, bullying, undermining and harassment. And whilst I appreciate that Group 2, who have had a short time in the UK practice, their background statistics are very similar, and I would worry that without the right support, Group 2 could very easily become Group 3. And I think we need to specifically look at these areas. So what did BME SAS tell me? And I had permission to share some of these comments, and they're quite pertinent about the themes that come back with relation to today's study days about exclusion and lack of recognition and value, but also racism, which can be direct and indirect. So one statement here, I've been asked to be a member of the interview panel for SAS recruitment, and the clinical director told me that a SAS doctor isn't needed on the panel. Well, I would challenge that, because we have a SAS charter that's adopted by in England and all 4 devolved nations, and it is very clear that one of the things we're aspiring to is getting SAS doctors involved with recruitment. So I would disagree with that and challenge that. Surgical trainees get preferential treatment, better support. Raised it before, nothing ever changes. That SAS surgeons can't progress if they don't get the equal support to what trainees get from consultants. So these things resonate really well with this group, and we need to look at these issues. Racism, I'll let you have a quick read of some of these comments, but one that stands out to me is at the top. So some patients I've come across are overtly racists, and they've even said, I don't want you to see me, you should leave, and I'm racist. And that was being said to a SAS BME doctor by an intoxicated patient. And as you can read there are a lot of other similar quotations about more direct and more indirect forms of racism. The state of medical education and practice in the UK, so SOMEP for short, found that BME doctors were consistently less likely than their white colleagues to report that there have been positive changes in their work experience due to the pandemic. Looking at the Academy of Royal Colleges, they produced a paper very recently, just last month, on the well-being of the SAS workforce. and found that, as we've said before, 30% of SAS doctors were bullied, undermined and harassed in the last year, and almost 45% of cases were from consultant colleagues, which again resonates well with what we said before about the hierarchical nature of the NHS. So what support is available for SAS? And this is directly answering the question posed to me. I'm proud to say that each trust within our region has a SAS tutor, and that also includes dentistry. We have good support from DMEs and MDs, and within local trusts, freedom to speak up guardians who can be there as a source of support to try and help alongside perhaps a SAS tutor tackle some of these issues. And I would always advise a SAS doctor or dentist who's in difficulty to contact their SAS tutor, their freedom to speak up guardian if needed, their clinical leads. For more tricky issues, every trust has a local negotiating committee, and it's important that SAS are represented on that to try and help negotiate things between HR and medical directors, etc. You will also have access to your BMA and relations officer, and the Northern Region SAS committee I'm a member of that as well, and that can be a useful platform. SAS tutors, this is just to say who they are and where they are, and the role of SAS tutors. We are a point of contact for support, advice, guidance across looking at developmental and educational matters. We have a SAS development fund, and it's important that we roll that out and support other doctors who are wanting to apply for CSER. It's also important that we roll out the SAS charter and support with induction.
Thank you very much, Mike. I'm really sorry, but we're really running out of time, and I have to ask the questions of the panelists. So I'm just wondering whether you would be able to share the slides with Richard, and you would have the slides available for everyone else after the talk. It's just we're running out of time quite badly.
Yeah, absolutely. I was just going to say regionally, there's a lot of support for SAS, including myself. There's national support, and I think in order to tackle bullying, harassment, undermining, we need to change our attitudes, look at our awareness, be more supportive, bring out the best, and work with others to challenge and change. Stamp it out, or as you would say, knock it out. Thank you.
Thank you very much. We've got a couple of questions from the public, from the audience, and also we've got one question for Dr. Nancy Redfern. Since Nancy, you've been involved in mentoring programs a lot, and you've been a mentor and also training the mentors. Have you ever mentored anyone who's been referred to GMC? And what challenges did you come across while mentoring somebody who's had been referred to GMC?
Yes, can you hear? Can you just wave if you can hear right? Yes, I've had the privilege of mentoring several people who found themselves at the wrong side of the GMC. I think the first thing is that they've already had what is described as multiple jeopardy. They've had an investigation in the hospital, the GMC have looked at things, there's possibly been some other sort of investigation. And in all of those, when they talk, everybody's listening for the facts. And what a mentor does is listen to the person. And so sometimes the most useful thing I think you can do as a mentor is to help the person just describe events and make a little bit more sense of what's gone on. They've often lost contact with colleagues. Sometimes that's because the trust or hospital in which they're working has prevented people, their colleagues, from making contact. Sometimes I think it's a personal sense of shame and horror at what's happened, and a feeling that they don't want to be in contact with people when they're in a difficult situation. So I think it's a really brave thing to do, to ask for support. Everyone's different and every situation is different. And I think the main and first thing is just to be there and to listen. But as people start to explore what's gone on, sometimes that leads to them being able to see just that first little glimpse of something that they can be in command of. And that business about taking back some control, I think, helps a lot. Julia was saying how Tom Bourne and that study showed that suicide rate amongst doctors who found themselves reported to the GMC is 100 times that of others. So trying to work out what might I be able to do, which little tiny bit of this might make me feel more human, more normal, to remember I'm a good doctor, but I'm in a bad situation. Because I think if you can see yourself as your more like your normal self, then your ability to demonstrate insight and to express remorse is much, much greater than if you feel absolutely drained of every last molecule of you as a doctor. So I think sometimes people don't quite grasp that a mentor will just help you be you. And I think it's one of the most valuable things that can be done. And I know Kathryn has also done some of this work, and it's a huge privilege. I really would recommend, when you find yourself in that absolute morass that Julia was saying, you know, get a mentor, and between the mentor and the person, you kind of chivvy yourself up to getting some of that list that she had sorted out. Does that?
I think that quite well follows on to the question from Julia. That's the question from the audience. From your experience, how can colleagues best support a doctor who has been referred to GMC?
Well, I think the very first thing is, you know, do not be judgmental. We like to think of ourselves as doctors as non-judgmental, but, you know, clearly from listening to our talks, you know, we all have that unconscious bias. You know, don't be judgmental and be compassionate. You know, if you discover that your colleague has been accessing child pornography, you know, that there is something very wrong in that person's life, and you don't know the facts of that. So it's just like I say, be non-judgmental, be compassionate, and maintain contact, or you know, don't gossip, and just try and be supportive and see. You know, I think there's this divide. It used to be like the deserving poor or the undeserving poor, and there's deserving illnesses, you know, the breast cancer, the whatever, and there's the undeserving illnesses or behaviours. You know, you have to, you know, examine yourself as a human being and relate to that person as a human being in a non-judgmental, compassionate way. And if you can be supportive, physically, fiscally, or if you can't, you don't feel able to be supportive, don't be non-supportive.
Thank you very much, Julia. There are a couple of questions for you about bullying and harassment. So the first question is from one of the doctors, says, where could I go for help if I have no success at raising issues through the freedom of speak of a guardian? I feel helpless and I'm losing the lip.
It's a difficult. There's loads of help out there, but I think you kind of need to divide it into two routes, because there's the help and support you need for yourself and your own mental well-being, and then there's the help and support you need to help tackle the bullying. So I think you need to look at it as two different things almost. They are interlinked, obviously. In terms of support for you, always go to like locally first, your colleagues around you. Is there someone friendly in the department that you can go and speak to? A little bit wider than that, the support available if you're a trainee through Health Education North East. If you're not, you're a consultant, there's help available through occupational health and support there. And there's also mentoring that Nancy talked about, which is an absolutely massive form of informed support that will really, really help you. I really would recommend, it's for doctors only at the moment, but the Practitioner Health Programme nationally is absolutely brilliant. And you just phone them up, book an appointment, it's free. It's the 24/7 crisis line that you can text as well. And if you go onto the Association and Anaesthetists website, there's a whole list of wellbeing resources that you can access. There's lots and lots of quick links there for help, and you can look at what's suitable for you. When it comes to tackling the bullying behaviour, that's really tricky and really difficult. But again, I would start locally with the people around you and near to you in your department. Try and talk to somebody about it, somebody that you can trust, and you can get help from there. From a trainee perspective, your educational supervisor might be someone to approach, your college tutor. A little bit wider than that, there's people like Kathryn at the Deanery level who will support people. And if you're a doctor working in a trust, I'm really sad to hear the Freedom to Speak Up Guardian wasn't supportive, and that's actually quite concerning because that's their role. And I think if that's not happening, somebody needs to know that that person isn't offering that support, actually. The HR department at Newcastle is brilliant. Karen Pearce is absolutely fantastic. You could definitely approach her. And there's lots of people within our organisation that I know you could approach, but it's going to be different wherever you work. But if you start in your department, you're likely to know where you can go to get help. But please do get help. It's really hard to go and seek help, and I think even thinking about it is a massive achievement, and it means you've made a step forward and you're getting through to sorting out that problem. Because actually, normally the hurdle is making that first step. So well done for doing it, and I hope you get the help that you need, and hopefully we can point you in the right direction.
And there's another question, quite an interesting question, saying that do you think bullying might be due to the bully's own experience in the past of being bullied themselves?
It's really interesting. When I've been in situations, I think we all have, haven't we, where we've seen or experienced bullying. Quite often I think that the person is behaving like that because they don't have the tools to cope with the situation that they're in. And I always give them the benefit of the doubt and think that. I don't think people are bad. I just think that people they can't control their own emotions, and they're not able to deal with the stress that they're under at the moment, and they're taking it out on me. And that's how I like to look at it and think, well, actually, that person needs a bit of help and a bit of support. And with some of the resources that we're trying to put out there with the infographics that I showed you, are kind of getting you in there to offer a bit of that support and say, actually, look, I noticed you're shouting and you're a bit stressed. Is there anything I can do? I think that's a really good way to approach it. And I suspect, patterns of behaviour are learnt. And if you grow up in that environment, or if you are subjected to that environment at work, like teaching by humiliation, that's something that then you think is an all right thing to do to your training. So it's all about us watching how we behave and just doing it better, because we can change this, but we all have a responsibility within that.
And there's another question again about bullying and harassment, asking, is gaslighting a form of bullying managers often use to keep people in their place?
Gaslighting is really, really, really difficult behaviour, and the whole point, well, the way it's described, isn't it, is that you as the victim start to feel that you're going mad, and the person is making you think that, and that's the real problem with it. I think if somebody has picked that up, it actually means that they've noticed it's happening. And with gaslighting, the danger of it is that the victim never notices it's even happening until they're out with that situation. The fact that someone's noticed and picked up on it is fantastic, because it means that they can act and they know that this is happening, and then they can make steps towards making that change. It's an awful behaviour, and it shouldn't be tolerated.
Kathryn, I just would like to ask you, have you got anything to add or anything to comment on any of the answers or the questions? Kathryn is muted. We can't hear Kathryn.
Yeah. You're still muted, my dear.
We can hear you now.
I apologise for not unmuting myself. It's a habit I get because I talk so much that I find I must put myself on mute. Yes, I think we've had two talks that have covered a massively wide breadth of topics that are terrifying to doctors. I think the thought of being referred to the GMC strikes cold fear in all of us, and the bravery you need to come through that process is enormous. And I think both Julia and Nancy have told us exactly, you know, you do need to put yourself at the centre of the solution, as well as feeling that you're the problem, and seeking help and support is key in that, and understanding that you need it and don't go it alone. I think Julia was very clear on that. I think from the bullying and harassment point of view, it is absolutely wrong and unacceptable, but it becomes a habit and it becomes a cultural habit, and I think we have to role model against it. And I think I myself have to be conscious that some of my banter is easily tipped over into bullying, and I must be careful with that. However, there is something also about not accepting the premise of the bully, that it is them, not you, that you are not, it is not your position in life to be bullied and receive bullying, and that's not to become aggressive and unpleasant in response, but it is in order to maintain your own personal well-being and resilience. That it is to understand, as Roo said, that it is the other individual who has the difficulty. And that's incredibly difficult when you're feeling vulnerable and weak. And if you're in a hierarchical or social or ethnic context where you already feel vulnerable, it is much more difficult to maintain that resilience. And I think, as Nancy and Roo and Mike have spoken about, having a wider lens on the problem and understanding you can get support from other rational human beings that can help you understand that yes, it isn't me, and that I can choose how to respond to this bullying. I think the individual who put the question, who's sounding desperate, that is absolutely appalling and awful. And your journey now probably starts with your own personal improving your resilience, widening your lens, understanding that you're probably not alone in receiving this behaviour, and that to talk to other rational human beings and start to re-establish yourself as a worthwhile person who can then respond to the bullying, because it is incredibly undermining. And yes, as I said before, having come through medical training as humiliation, I absolutely understand that. But one of the reasons I haven't noticed bullying is probably because I simply don't accept that I'm not fabulous. Therefore, I can't possibly understand how anybody could possibly be bullying me, and that they're just having a bad day.
Thank you very much, Kathryn, and thank you very much for the speakers and to the panelists as well.